Hello, and welcome to today's Lunch and Learn Prostate Pressure Relief. I'm Dr. Steve Reinches, the President and CEO of North Kansas City Hospital and Meritas Health. Thank you for joining us. As a man ages, his prostate grows. It puts pressure on the urethra and can obstruct urine flow. This condition is also known as benign prostatic hyperplasia. Our expert speaker today is Dr. Gerald Park. He will discuss the symptoms, diagnosis, evaluation, and treatment options. He'll spotlight aquablation. As the name implies, aquablation combines both water for the removal of prostate tissue. North Kansas City Hospital was the first to offer this new, innovative, FDA-approved treatment in Kansas or Missouri. Dr. Park has been a urologist with Kansas City Urology Care for almost 25 years. He's board certified in urology. He earned his medical degree from the University of Texas Medical Branch in Galveston. He completed his residency in general surgery and urology at the University of Kansas. If you have any questions about our topic today, please submit your questions using the Q&A feature below. We will respond at the end of the presentation. And now, please join me in welcoming Dr. Park.
Dr. Reiches, thank you very much for having me here. It's a pleasure to talk about prostate. That's my expertise and that's my thing. So here we are. As Dr. Reiches said, I grew up in Texas, did my schooling there, and now here I came for my residency at the University of Kansas, and I've worked here at North Kansas City Hospital for almost 25 years. It's been a real privilege to be here. I am a consultant for Prostate Biorobotics. It's the company that makes Aquablation machine. So in terms of today, what our goal is, there's three things. We're going to find out what is BPH, or benign prostatic hyperplasia, what your treatment options are, and why you should consider aquablation therapy. First of all, what is benign prostatic hyperplasia? I just say BPH, it's a lot of words. So anyways, what is BPH? First of all, what is the prostate? We have to understand what the prostate is. The prostate is a small gland that plays an important role in male sexual function. It lies between the bladder and the penis, and it's important for ejaculation and erections. Over time, all men's prostates will grow, and as it grows, it will start to affect urination. Now, in terms of BPH, we know that over 40 million men in America have BPH. Starting the age of 50, 50% of men will have BPH. And every decade afterwards will increase about 10%. So on average, our 60, 70-year-old man, about 70%, up to 80% of them will have BPH. Now, BPH is not cancer. So prostate cancer and BPH are two separate things. And today we are only talking about BPH. So when we look at the BPH, what exactly is causing all the troubles? And it's something called the transition zone. So in our diagram, we can see where the arrows are pointing to the transition zone, and the blue circle shows in the prostate. That is the part of the prostate that surrounds the urethra, or the urine tube that goes through the prostate. As it gets bigger, as you can see in the right picture, it compresses the flow of urine. But you can also see in the prostate, there's other parts that are important for sexual function, specifically the ejaculatory duct. So our goal in treating a man's prostate is to only treat the transition zone and leave alone the ejaculatory ducts. So therefore, we don't interfere with sexual function. So when it comes to BPH symptoms, there's two big categories. It can be trouble holding the urine or trouble emptying the urine. In terms of holding the urine, we think about urgency. You need to go urgently or immediately. We think about frequency, the need to urinate more often than normal, nocturia, which means waking up at nighttime to urinate, and incontinence, losing urine. Emptying the bladder issues would be things like straining, where you need to push or strain to start the urination. Dysuria, meaning it kind of stings or burns. Hesitancy, where you have difficulty getting the urine started. A weak stream, instead of being a full stream, it dribbles. Intermittency, instead of it being a constant stream, it starts and stops. And ultimately, it can lead to retention, where you cannot urinate at all. And this will lead to an impact on quality of life. So all men, over time, as they get these symptoms, will affect how they live their lives, whether it's waking up at nighttime, whether it's limited activities, sexual dysfunction. Those are all things that quality of life is important. And what I tell my patients is your bladder should follow you. You don't follow your bladder. And what I mean is when you plan to go out, do you, first of all, think about where the restroom is, or do you think about what you want to do? And so if you think about restroom before you think about what you want to do, good chances are your prostate is leading you instead of your prostate following you. So in terms of consequences of BPH, there's some medical things that can actually happen as well too. You can get bladder stones, you can get blood in the urine, you can get infections, you can get bladder damage, you can need a catheter, you can even develop kidney failure. So you can see in the diagram, that's a picture of a bunch of stones in the bladder. And it's because the prostate's enlarged, it holds the urine then crystallizes and stones are formed. So this is one of the consequences that you'll see. In terms of diagnosis is, well, how do we figure out if someone has BPH or not? It's very simple. We can do a physical exam called a digital rectal exam where you feel the prostate. And we also will review your symptoms. And we're also going to ask you to do a questionnaire. And so a lot of guys don't realize that how much their prostate is affecting them until they start realizing, when I go to golf, when I go hang out with my buddies, when I go shopping, when I go travel, it's like, oh, wow, this is affecting me. You don't want to be the last one staying at the urinal at the Chiefs game. Now, in terms of BPH evaluation, as we can see in this picture, again, the transition zone is at number 3, or the blue circle. This is a small prostate, but as that BPH gets bigger, again, it constricts that flow. And the question is, well, how do we know it's constricting the flow? Probably the most important thing we do is called the International Prostate Symptom Score. How much is this really affecting you? We do the physical exam with the prostate exam, the PSA, which is a blood test that is actually also a screening test for prostate cancer. We also do something called a uroflow, which measures the flow rate, a post-void residual, meaning how much urine is left in your bladder after you've gone to the bathroom. A cystoscopy, which is a small scope, a litoscope we put through the urethra, through the penis, through the prostate, into the bladder. And the last thing is going to be a prostate volume study. Exactly how big is your prostate? We can use an ultrasound, a CAT scan, or an MRI for these things. So, like we said, the most important thing that we do is called the International Prostate Symptom Score. So I'm going to need a volunteer from the audience. And since you guys can't talk through the camera, I'm going to ask Dr. Righteous. So anyways.
I would love to volunteer.
Okay, thank you very much. So we're actually going to call him Mr. Steve. This is not Dr. Righteous speaking. This is Mr. Steve. He's a hypothetical 60-year-old man. And I'm just going to ask him a few questions about how is urination affecting your life? So the first question, incomplete emptying. And audience, feel free to kind of write notes for yourself and see what your symptom score is as well too. So how often have you had the sensation of not emptying your bladder, would you say?
So I just want to clarify first, it's hypothetical.
Yes, this is not you. Exactly.
But number 2 on these questions, is there a time period that I should refer to in this hypothetical case?
Good question. So I would say, think about over the last month. Over the last month, how would you answer this question? So over the last month, how often have you felt the sensation of not emptying your bladder?
I would say less than 1 in 5 times.
Okay, good. Let's click that one. Frequency. How often have you had to urinate less than every 2 hours? So going less than 2 hours is considered frequency. So less than 2.
I would say less than half the time.
Less than half. Good. The next question is intermittency. And that refers to how often have you found that your urination has stopped and started several times during your urination?
I'm going to say not at all.
Not at all. Okay, good. Urgency. How often have you found it difficult to postpone urination? You got to go, and that feeling is very strong.
I would say less than half the time.
Okay, good. How about weak stream? How often have you had a stream that has felt weak to you?
Well, I'm going to clarify this question.
Okay.
And I will answer the question,
Yes.
but is it normal for a 60-year-old man to have the same strength of stream as a 20-year-old man?
That is a very good answer. Very good question. The answer is obviously not, but we tend to accept that my stream should be weak, but it doesn't have to be.
Mhm.
So to you, think about maybe back compared to 10 years ago, 20 years ago, or when you're at the Chiefs game and you see 5 guys come and go while you're standing there. That's how you can know you have a weak stream or not. Or you
Okay.
listen to the guy next to you and you hear that rush and you see your trickle, so to speak.
At the Chiefs game, my hearing is not that good, but I will answer this question.
Yeah.
I would say less than half the time.
Okay, thank you. How about straining? How often have you had to strain to start your urination?
I would say not at all.
Not at all. Good. And then nocturia. How often do you think you wake up at nighttime to use the bathroom?
I would say 2 times.
2 times. Okay, good. And then overall, as we think about these symptoms that you're experiencing, again, this is Mr. Steve, it's not Dr. Righteous. If you were to spend the rest of your life with your urinary condition the way it is now, how would you feel about it?
I'd say mixed.
Mixed. Okay, good. All right, so let's look at the score here. This person has a score of a 9, is considered moderate symptoms, and he's mixed about it. So let's go back to our slide here. And what we're going to see now is that he kind of fits that moderate symptom category. Okay, so we have the mild symptoms, moderate, and severe. And so typically anyone who's going to be moderate and above are people that we really need to be thinking about getting treatment. Okay, and so if we look at this next picture, we kind of wonder, well, what does it mean? Is it just that the BPH is giving me some annoyances? But the reality is it can actually damage your bladder as well too. And this concept of bladder health is very important for us to understand. If you look at this diagram on the far left is a healthy bladder. Your bladder, this is a cystoscopy, meaning a scope that's put into a man's bladder. And we're looking at the inside surface of the bladder. It should be a nice, smooth surface, just like your skin is when you're younger. As you go to your right, you start seeing what they call trabeculations, this thickening, it's scar tissue, it's musculature that's getting thicker and thicker. And that means your bladder is getting unhealthier and unhealthier, and often to the point where it can be permanently damaged. And that's situations where you may know a relative, a friend, a grandfather, a neighbor who had to have a catheter. That's what happens is if the bladder gets damaged, it can no longer function properly. It can no longer push the urine out and you get damage. So what are your treatment options? First of all, depending on the severity of symptoms, it goes from less invasive to more invasive. Watchful waiting, as it implies, is just watching. Just live with it because it's very minor. Medications is usually the next step. And the last option is going to be surgery. Now, the way this is shown, this is kind of the typical mindset that we would have because we'd always go from medication to surgery. But today I'm going to explain to you why surgery is actually an option we can pick earlier on. And so here we go next. The first one is treatment options. Mild symptoms. Again, if you did that questionnaire and you're between 0 and 7, this is probably you. You can wait and see how things go. For most men, the prostate will continue to grow and get worse with time. One thing we know about BPH, it's not reversible, meaning on its own, it doesn't spontaneously get better. So what you have is what you have. And typically it'll be stable and it'll just get worse, either very slowly or sometimes very quickly. And so there's this, example of Chris. He goes, I waited way too long before I got any help. It was horrible. For years, I was literally waking up 5 or 6 times every night to go to the bathroom. And so a lot of guys just think, you know what? It's just part of getting older. This is the way I am. This is the way it has to be. And today we're going to realize it doesn't have to be that way. Treatment options, next line is going to be medications. So medications have often been the first line of treatment. And medications really made a big difference. But one thing we realize about medications is they fail in up to 30% of men. So it does work in 70%. But the funny thing is, even the 70% that do well with medications, if we look at compliance, what's the likelihood that man is going to continue on medications? And the reality is after a year, only about 29% of men. And at 4 years, 13% of men. And I can say that that's true for me. My wife tells me every day, take your vitamins. I think I was good for about a week, maybe a few days. But then after that, it's like, you just forget about it. You just can't get yourself to take these pills every single day. The other thing we realize is as people are having more and more medications for other diseases, there's a lot more interactions of medications. And so we realize that that's something we have to keep in mind. And for those of you who are older as well, there's something called this floppy iris syndrome. So if you ever have to see an ophthalmologist, you always have to tell them that you're on a BPH medication because it can affect the success of cataract surgery. So there are some serious significant things with medications we have to be mindful of. Now, surgery. So people always equate surgery as the last resort. And that used to be the case, but is what we realize now as time has gone on, surgery actually is more effective than medications and actually has fewer side effects. Now, many of you maybe heard stories of a grandfather or someone older who had quote unquote the roto-rooter surgery, the old famous, as we call it, TURP. Because back in the day, there's only a single surgery that we had for BPH. That was the TURP. It worked great, but unfortunately had a lot of side effects. If you look at the right side, under surgical therapy, depending on the size of the prostate, small, average, or large, you can see we have a plethora of options of BPH treatments. And so what we realize, though, as time has gone on and more technologies have come out, really, we want to take care of the urinary obstruction problems, but we want to maintain the sexual function of the prostate, the main original function of the prostate. And really, the two procedures that have shown to be the most effective in doing that are going to be a urolift and an aquablation, which will be the focus of our talk today. So you can have our cake and eat it too. We can take care of the urinary part, again, that transition zone, if you remember from our anatomy picture, but preserve the ejaculatory ducts, the other part of the prostate that is so important for sexual function. And so that's why surgery has really moved to the forefront of treatment when it comes to prostate health. Now, the urolift is a very good procedure for what they call small to average size prostates. What's nice about it, it's outpatient, no catheter, preserves sexual function, and no incontinence. You can see on the diagram, the pictures go from left to right. The first one is an untreated prostate enlargement. And then the middle picture shows the deployment of what they call the urolift tab or device. And what it does is it pinches the tissue to open up. So it's like a curtain. So if your prostate's like a curtain, you put your arms between the curtain, you spread it open, and the urolift is what keeps it open. Okay, so it's really nice because it's really very little recovery. Again, no catheter is really the key component with this. And you can go home the very same day. And that's something we do a lot of these surgeries here at North Kansas City. The other one is going to be aquablation. That's going to kind of be our focus today. So the aquablation is best for average, large, or very large size prostates. And what's nice about it, it can be adapted to different prostate shapes as well too. The way it works is it uses a powerful water jet. It's kind of like your power washer when you clean out your driveway. It uses this water jet to clear out tissue. And because we're able to tailor the treatment, we can tailor to that transition zone, the part that's blocking the prostate, but we leave alone the part of the prostate that's important for sexual function. So it preserves sexual function. And there's no incontinence. We know the anatomy and we can outline the anatomy so that we don't worry about any leakage. It does require an overnight stay, and you do have to wear a catheter for either a few days or maybe we take the catheter out the very next day. Now, this treatment is personalized. And so we can see, I know this is a very technical slide, but the point is that there's different size and shapes prostates, and we can make these very tailored treatments depending upon your prostate size and shape. And we know that it works very well. It works just as well as a traditional TURP surgery. So our gold standard surgery to TURP is going to be matched by this aquablation, but it's better because there's less side effects. And again, there's zero impact upon erectile dysfunction, orgasm, sexual desire, and overall sexual function. And nearly every man will preserve their ability to ejaculate. For men who've been on prostate medications, even medications, as we know, have a 30 to 40% chance of affecting sexual function, whereas this surgery has 0 to just less than 10% chance of affecting it. And the nice thing is it can be worked on all sorts of sizes and shapes. And it's a very consistent, predictable, good outcome. And in terms of leakage, 99% plus don't have any kind of leakage after this surgery. So we're going to look at this little picture of how this works. So let's go ahead and start this little cartoon, but you can kind of see this little diagram on the right side. This little video shows how this water jet goes back and forth, and then what it does is it sweeps through the tissue, removing tissue to that green dotted line, which I, as a surgeon, have outlined. And by knowing the anatomy of your prostate, I know the part of the prostate that's affecting urination, and I know the part of the prostate that's important for sexual function, and we're able to take care of the bad part, but keep the good part. And by doing this, we get this very, very good result with very little side effects and no worries about leakage at all. So that's how this procedure works. So why choose, again, Aquablation? It's low rates of irreversible complications. Again, it uses this water jet, it uses ultrasound. We know exactly where the treatment's going. We're confident that it's very precise. We can do it over and over from patient to patient and get a good, consistent result. And long-term relief, because we're removing tissue, we know it's durable. And we're talking years and years. We're talking decades of relief. I never, unfortunately, guarantee anything lifetime. As we know in medicine, there's no such thing as lifetime guarantees, but this is as good of a guarantee as we can give. What to expect in recovery. So again, most patients will spend 1 night in the hospital. And as with most BPH surgery procedures, you will have a catheter initially. You'll be able to sometimes leave the hospital without a catheter or go home for a couple of days. There will be a little bit of burning after the procedure. There's nothing that's completely free of any discomfort. So there's going to be a week or two where I tell my patients, you may not like me for a week, so please don't call me. So wait till after a week, then call me and tell me how you're doing, because that first week you may not be too satisfied because of some of the discomfort, but it's something that's very doable. And we give you medication so you can get over it. And you'll be able to resume your activities fairly quickly after everything. And it's really been an amazing thing that we here at North Kansas City, we're the very first in Kansas and Missouri, in the whole Midwest area, to do it. In a very short time, we got to 200 cases, wow, which has been a phenomenal thing. Even from the company, they said we've been the most successful program they've ever launched. And a lot of it is because of the support of North Kansas City Hospital. Dr. Righteous, thank you. And just the support of the community and the people's recognition that this is a procedure that we've not had here in the Midwest, and we are now offering as a frontline cutting edge technology that, again, will provide great relief for the prostate with minimal side effects, particularly when it relates to sexual side effects. So I'm just so excited that we can do Aquablation here and have this world-class technology here in the community.
Well, I appreciate the comment. North Kansas City Hospital, when invests in cutting edge technology, Aquablation is one. We have additional investments in our advanced cardiac care, and even the operations of the hospital. We're now deploying artificial intelligence platforms to make it a more friendly customer experience, patient experience, but also to make it more efficient for the hospital. Yes. We believe in investing in the great physicians like you and the great team that supports our healthcare mission. So thank you for that comment. Yes. But we have time for a few questions.
Okay, great.
So I have to read, here's the first one from the audience regarding urination frequency. This is from the audience. I tend to drink a lot of water, tea, and juice, especially in the summer. Sometimes I need to go about every 2 hours or so, and the urge becomes fairly strong after a couple of hours. Is this normal due to drinking a significant amount of fluid?
That's a great question. So one of the things when it comes to urination, it's not 100% because of the prostate. There are things like your diet and activities that will affect the frequency and urgency of urination. We do know that there are bladder irritants, particularly, as you mentioned here, the caffeine, which is found in tea, the amount that you void. Those are all things that will indeed increase frequency and urgency. And so that's why it's important when you come and see a urologist that we kind of sort through what's due to behavioral things that you can change, and what's things that you cannot change. Your anatomy, your BPH, that's something you cannot change. And so great question. And the only way we can know for sure what's due to what, come and get checked out.
Okay. Well, this will dovetail to the next question. Since it's a given that the prostate's going to grow, and at what age should a patient expect to have symptoms of an enlarged prostate? What's the range when you should begin to notice symptoms? You
know, actually, we see patients even in their 40s and sometimes even 30s. But I would say the typical patient will be once they start hitting 50s. That's really when we start seeing, again, we know statistically speaking, about 50% men by the time they turn 50 will have enlarged prostate. Does that mean they all have symptoms? Not necessarily, but they do have that anatomy, that anatomical enlargement that does portend to start giving those symptoms. And the thing that happens is it's often a very slow, gradual type of transition. It's not like all of a sudden I wake up and it's like, oh my goodness, I'm having all these troubles. It's one of those things in hindsight. And often I get comments from the spouses often saying, I've been telling him forever and ever, do something about it. You're waking me up at nighttime. I can't plan our day. We can't plan these trips because you're always worried about the bathroom. And so I know as men, and me as my wife, who's my better half, I want to listen, but for some reason I can't. I don't know why. I just can't listen to her, but I should. And so men out there, listen to your wives. If you hear a comment once or twice about your urination, that's probably a good sign that your prostate is giving you troubles. But 50 is a good age to be thinking about, I need to get my prostate checked out.
Okay. A couple more questions from the audience. In general, how bad does one's BPH have to be for most health insurance plans to cover the cost for all the screening tests?
Oh, good question. So it's really going to be that symptom score. If you remember that little sample that we did with
On a hypothetical person?
Mr. Steve, again, that was Mr. Steve. And if your score is 8 or above, that is medically proven to show that that warrants an investigation. So that's why that's something you can do at home. And if you'll get a take 5 points, was it, or some kind of sheet, I know, where you'll get these 5 take-home points, and on there should be a link to do that IPSS score, again, that symptom score. So go ahead and do it now or afterwards. And if you score 8 or above, it warrants a discussion with a urologist.
That's great. Another question, how quickly after the procedure, and I assume they mean aquablation,
Yes,
will I be able to resume sexual activity?
I would say about a week. About
Okay.
a week is pretty typical. And that's kind of the resumption of just normal activities about a week later. Usually that first week, you kind of want you to lay low, kind of take it easy. But about a week, that's when we're really going to let you really kind of get back to doing what you want to do.
Okay. Another question from the audience. Is the urolift procedure or the aquablation procedure something an 87-year-old male should consider?
Great question. One thing that we're seeing, we used to kind of have this mindset, and it's not just toward BPH, but just health in our older population. What we do realize is that population is getting older and they're staying healthier longer. And so things that we put off in taking care of, we just kind of said, well, it's just part of aging. But the reality is that men are living in their 80s and 90s more and more frequently. And so there is no age limit of being treated for BPH. And if anything, I would say get treated earlier so that when you do turn your 80s, you're not messing with this problem now. Mm-hmm. And so, but if you're in your 80s and you've put it off, it's never too late. And that's what's great about this aquablation or the urolift, as we mentioned, is that because they're less invasive, they're so much more quicker, more efficient. The anesthetic time is much shorter. Mm-hmm. So the urolift, for example, maybe takes around 10 or 15 minutes to do. The aquablation on a large prostate may take us like 30, 35 minutes to do. Wow. In the past, if we treated that same prostate with the old-fashioned roto-rooter surgery, it would take us an hour to do. So imagine now we've now taken an hour-long surgery and we turn it into a 10, 15-minute procedure or a 30-minute procedure. It's so much safer for the patient that they have a shorter anesthetic, lower side effects, and the results, honestly, are just as good as the old-fashioned TURP. And so that's why, to me, it's an amazing technology that we have this world-class, cutting-edge technology here at North Kansas City Hospital. And as you spoke about AI, aquablation is truly the first automated robotic surgery on the market, meaning once the surgeon, myself, makes the treatment plan and I hit the start button, the robot does the rest of the work. It knows where the line of resection is. It knows to not go beyond there. It knows not to get into danger because I've outlined the safety boundaries. So for those of you who have a Roomba at home, you make the perimeter of where it needs to be cleaned, and the robot does the rest. You go and do your other things. Now, I'm not drinking coffee. I'm not playing games while the surgery is going on, so don't worry about that. But the robot is able to do the surgery within the confines that I've defined. And not just that, it's able to do it so much quicker. So instead of me using a manual screwdriver, it's like a power tool. It just mows right through it. And so because it's so efficient and quick, lower anesthetic time, lower risk, quicker recovery.
So a couple more questions. Fascinating talk, and we may need to get all the take the time to get everyone's question answered,
Yeah.
but these are real questions.
Yeah.
Here's somebody reading, I presently take tamsulosin, 1 tablet per day. Should I be taking 2 per day? And does tamsulosin cause blood pressure to lower?
Great question. So tamsulosin is one of the most common drugs we use, and it works great for the prostate, but it does have a potential side effect of lowering blood pressure. So dizziness or hypotension is one of the most common side effects of it. And so that's why often we tell men to take it at nighttime, so that when they do get dizzy, they're already asleep. And what we realize is there's a lot of drug-drug interaction. The other question was, should I take 2 pills? That's really going to be up to you and your doctor. I can't answer not knowing your situation. But that is something that we're realizing more and more is this drug-drug interaction. And like with tamsulosin, again, for those men who are older, who may have cataracts, let your ophthalmologist know. That is a very important thing in terms of determining your success of cataract surgery, because it's floppy iris syndrome into Flomax. And so that's why we're really advocating. In the past, we didn't advocate surgery as much in men for BPH because medicines worked decently. Medicines, honestly, are just a Band-Aid approach. But the old-fashioned roto-rooter surgery to TURP is still an excellent surgery. And in experienced hands, you'll get a great result with very minimal complications. But what we realize is it was very hard for us with a clean conscience to really push everyone towards surgery unless they really, really needed it, because there are risks with it. But with this now lower risk surgery, aquablation or urolift, we're able to give people these great results of the TURP with minimal complications. And the reality is that those complications are actually less than medication. So everyone thinks, oh, if I take pills, then I won't get complications. The reality is the side effect of pills over time are higher than the side effects and complications of surgery.
Great, great. Well, thank you very much. A link for the questions to evaluate BPH will be sent. I want to thank you, Dr. Park, for this really fascinating presentation. We hope the presentation was both informative and helpful. And please join us December 19th for Stand Up to Hip Pain with Dr. John Eggers, an orthopedic surgeon with Orthopedic Health of Kansas City. Again, thank you for joining us and have a good afternoon.